afternoon, everyone. Once again, it's my pleasure to be here today. My topic will be titled Conjunctival Lesions, Histopathological Review in Tertiary Hospital in Nigeria. These are the authors. I have no financial disclosure. As a long introduction, this study was carried out in the University of Calabar Teaching Hospital in South Nigeria over a 10-year period. And you can see over here the capacity of our hospital. Conjunctival is transparent because membrane lining the inner surface of the eyelids and components of the several lesions. And we all know the lesions consist of benign, pre-malignant, and malignant lesions, and to present diagnostic dilemma to ophthalmologists all over the world. Factors associated with conjunctival epithelial lesions include chronic solar irradiation, infections with human papillomavirus, HIV virus, being older in age, as well as the male sex for the sub-Saharan African, and having testing. Accurate management of this lesion depends on malignant potential, impact on vision, as well as cosmetic effects for the individual. However, surgical biopsies may be complicated by corneal scarring, which may deter operative interventions. The aim of our study was to describe the pattern of histopathological diagnosed conjunctival lesions in our hospital. We did a retrospective study which spanned through a period of 2010-2015, as well as 2017-2022. We obtained records from the histopathological lab department and categorized our lesions based on benign, pre-malignant, and malignant lesions. We decided to look at the prevalence of various types of conjunctival lesions and try to find out the association between conjunctival lesions and social-demographics associated with the lesions. Thereafter, we did a descriptive analysis and using tables and frequencies. In total, we obtained 85 conjunctival specimens from the records, and the mean age we saw was 38 years. And then we also discovered that we had a male preponderance in the records. So we had like 55% males had conjunctival lesions, and all cases were unilateral. This bar graph shows the frequency of the various categorization of lesions. Pre-malignant ranked highest, giving about 28%, and then for the benign were pterygium ranked highest. Then CIN was in between. The mean age of the conjunctival lesions over years in our institution range between the 4th to the 5th decade of life in all categories of the conjunctival lesions. This graph is showing the sex distribution. You can see that in the malignant, the malignant and the pre-malignant for the male ranks highest compared to the female. But we had like an equal distribution in the benign tumors for male and female sex respectively. Our study showed that malignant conjunctival lesions were the most common type of histologically diagnosed lesion, with benign and pre-malignant being the second and third leading lesions recorded anyway. And the average age was shown to be in the 4th to 5th decade of life. Results from our study are compared to several studies done in Nigeria, where squamous cell carcinoma was reported as the most common conjunctival lesion in 25% of the population studied. And our study also collaborates with several studies done in sub-Saharan Africa in general. Thank you very much. I would like to use this medium to say thank you to Eye Cancer Foundation who sponsored my fellowship at Shiva Eye Center. It was quite a great opportunity for me to learn so much. And I'd like to say thank you to Dr. Vicky Daye and Professor Fabian, who have been great mentors to me. Thank you very much.
Histopathological analysis over a 5-year period in a tertiary hospital in Accra, Ghana. There are no disclosures to make. As you all know, and as has been stated this morning, ocular surface squamous neoplasia comprise a wide spectrum of lesions affecting the corneal limbus and conjunctiva. They may be benign, pre-invasive, or invasive carcinomas. Early diagnosis, as we know, is essential to prevent increased morbidity and mortality. And histopathology is crucial in the diagnosis and course of treatment of OSSN. The aim was to report on the histologic spectrum of OSSN seen at the Kolego Teaching Hospital, the Department of Pathology, and it was a review of reports that have been issued from January 2014 to December 2018. Information retrieved or collected, including the biodata, presenting complaints, clinical diagnosis stated on the request forms, types of biopsies submitted, histopathology, diagnosis made, the grades of invasion that were recorded, and they were further categorized into benign, pre-invasive, and invasive lesions. The results. A total of 291 ocular pathology cases were seen over the period, and 52 of these were OSSN, constituting 17.9%. The mean age of the patient was 47.5 years, and majority of the patients were female. The record of the presenting complaints, in fact, some of the records were deficient of information. So there were only, for presenting complaints, while the patient presented, the record could be retrieved for only 34 out of the 52. And all of them presented with a mass on the affected eye, and only one indicated that there was pain associated with the mass. The duration of presenting complaint was also recorded for just 14 out of the 34 samples, and these range from 2 to 60 months. In terms of the histopathologic diagnosis recorded, majority were squamous cell carcinoma. And majority were the invasive type. Also, about 50% of them showed a well differentiation in terms of the histology. So ocular surface neoplasm accounted for 17.9% of all ocular pathologies. The commonest type of OSSN was the invasive squamous cell carcinoma, which accounted for almost 54%. 50% showed well-differentiated squamous cell carcinoma, but there was incomplete record of clinical information on the request form, an area that the department has started working on and engaging the eye department on appropriate filling of forms today.
Thank you very much, Vera. Just take a question from the audience, if there is any. Can you enlighten us about how, on histopathological basis, you made the difference between CIN and the invasive squamous cell carcinoma?
I hope I can attempt, but just as I said, this should have been presented by the pathologist who made this. But I think I don't know whether they use only histology or, immunochemistry comes in, but definitely they have a system of looking at
Okay, so basically, so it's the basal lamina, so you can stain it, and one is invaded very much. Do you know if any complementary therapy have been done to surgery in your group?
Actually, back home, they also use topical 5FU, and then also for surgery, because quite a number of the patients present quite late, and sometimes concentration is also done. So nucleation and centrifugal surgery plays a major role, but for the pre-invasive and then the CIN, they tend to use topical.
Thank you very much.
It's my honor to represent lower and middle income countries and discuss about the barriers to care in the treatment of OSSN. I'd like to thank ISOO and Dr. Didi for this invitation. So some of the barriers which I saw in the treatment of OSSN as well as in general in the ocular oncology are late presentation to the hospital, lack of awareness among general ophthalmologists regarding the disease, the limited number of specialists treating the disease, lack of diagnostic and therapeutic equipments, unavailability of necessary medications, limited ocular pathologists, and even children who are seen to be affected as well. The patient-related barriers are late presentation. The patient tend to stay at home even until they see a large mass or something like this. This is a usual presentation in our setup, or something like this around where there is a perilimbar almost 360 degrees involvement by the OSSN. And the most severe ones are where we don't even see the cornea and the mass has involved the medial canthus, caruncle, even inferior fornix, and the superior fornix with a variety of multiple masses. And in these cases, we need to do exenteration because we cannot save the eye in these severe cases. So why do patients present late in our setting? First of all, because of lack of awareness about the disease. And also, even if they are aware that there's something wrong in the eye, because of the sparse healthcare facility, they are not able to go to a hospital or eye care facility on time. The travel time for them may be 3 to 5 days, sometimes by road. For example, this is a map of Nepal, which is only about 880 kilometers. And there's only one tertiary eye care hospital giving treatment for giving the ocular oncology services in Kathmandu. And for them, some of the dotted ones are the patients from where we get the regular patients. And for them to travel, the farthest one could be just about 21 to 22 hours by bus, even though it's not so far by kilometer wise, because of the mountain regions, they take a longer time. So when they visit a healthcare personnel, first they visit primary healthcare center, which will be seen by a health assistant or ophthalmic assistant. Then if they find something suspicious, then the patient will be referred to a general ophthalmologist in the nearby hospital. If the general ophthalmologist, sometimes the early lesions, they may be confused with episcleritis or a pterygium or something, so they send the patient off with some topical drops and lubricant drops. And when the patient fail to follow up, and when the mass is visible, when the general ophthalmologist diagnoses it, then it may be late. And that is a time where they reach the ocular oncologist. And as I told you, there's only one dedicated ocular oncology center in Nepal. And so we have limited number of specialists also. We do have 28 cornea surgeons, but not all do OSSN. And even if some do, they may not do the proper techniques, and the protocols are generally not followed. And the next barrier is the lack of diagnostic and therapeutic equipments. In our setting, Rose Bengal staining is not a regular practice and not readily available. Anterior segment OCT is available in only one hospital, and we have been using it since 1 year only. The cryotherapy is available only in the 2 hospitals, and there's no in-house pathology lab in those hospitals. The amniotic membrane graft, because the lesions are large, we need to use the amniotic membrane graft after the surgery for reconstruction, and those are also available in 2 hospitals only. And plaque brachytherapy is not yet available in Nepal, and we need to send the patients with invasive squamous cell carcinoma to India for plaque brachytherapy, Otherwise, the next option would be enucleation. And going to the another barrier, that is unavailability of necessary medication. The current first-line therapy for treating OSSN, that is interferon alpha 2b, it not registered and not available freely. So some patient, we ask the whoever needs the whoever are posted for medical therapy, we tell them and ask them whether they can bring it from India. And some of them, they do bring it from India, and it costs USD 30 per vial, and one course of 2 months costs about 242 USD. And it is for the people from our country, it is quite expensive for them to afford. And then the next best line of therapy, 5-fluorouracil, it is cheap in Nepal, about USD 0.3 only, but it is not readily available and not popular. People like cornea surgeons, they are not aware of this, of the use of 5-FU, because they have been used to using mitomycin since long. And the mitomycin is, yes, it is available. It's cost USD 7 per vial, and we need 4 for the course of like 2 months. But because the mitomycin is so toxic that many patients land up with getting a limbal stem cell transfer as well. Hence, the medication, there is a barrier of freely availability of medications and its use as well. And next, as I told you, we have seen children being affected as well. So at Tilganga, we did a 5-year retrospective study on the pediatric ocular surface squamous neoplasia in the absence of risk factors and systemic conditions. These patients which we studied did not have any systemic or other risk factors like xeroderma, HIV, or SPS B or C, or they were non-smokers. And in the last 5 years, we saw 16 cases aged between 6 to 18 years old. And all the eyes were histopathologically proven to be OSSN. Among them, 9 of them had CIN1, 56%, 5 of them had CIN2, 31%, and 2 of them had CIN3. And none of them had an invasive type of squamous cell carcinoma. So since it is present in children, many of us may take these patients as a benign lesion or some inflammatory condition. So these children's diagnoses are often missed. And next is we have a limited ocular pathologist. We just have 2 trained ocular pathologists in Nepal, and they are also not in-house. They are practicing in a different, one is practicing in a different city and another in a different private hospital. So after doing surgery in our eye center, we need to send the patient or visitor to send for the pathologist in another center. And it takes about 1 week or 10 days to get the reports. And some of the cases which are done outside by general ophthalmologists or cornea surgeon are sent by their own general pathologist. And when this reporting is done by them, the margins are not commented and the base is also not commented upon. So it is difficult for us to manage further. Hence, a typical case scenario would be a case operated elsewhere without clear margins and without cryotherapy will be referred to us in the tertiary care center with query OSSN, and histopathology shows conjunctival squamous neoplasia, no margins not commented on as a tissue received in pieces. That means it was not clearly marked and sent to the pathologist. And the base is often also not commented upon. And it will be referred to us for further management. And this is a difficulty for us to manage because we are not sure about the base. So in those cases, we give adjuvant chemotherapy for the margins and wait for and put the patient on close follow-up. So how to improve from our level? We can educate the general ophthalmologist regarding the severity of the disease, regarding the morphology of the disease, and the importance of early follow-up, early referral to a best center, and also advice for cryotherapy, and to teach the cornea surgeons to send the proper samples properly labeled to ocular pathologist. We can also advocate to make the interferon and the 5-FU available easily. And lastly, the proper counseling to the patient regarding the severity of the disease is important so that the patient come for regular follow-up to us. This is all. Thank you very much for your kind attention. I'd like to thank Eye Cancer Foundation for providing me with the travel grant.